Providers, if they're trying to determine what type of access a patient needs, you'll start up at the right. Is a patient hemodynamically stable? Are they requiring hemodialysis? I'm not going to go through everything in detail, but it's a really great reference. It takes you down into if they're going to be requiring a tunneled CVC or a regular CVC based on how long they're going to be requiring dialysis. And on the left side, based on the types of therapy that they're going to be getting and for how long they're going to be getting that therapy, you can determine if the patient's going to need a shorter term access like a peripheral, an arrow, and then we move into PICs, tunneled central lines and metaports. Those are for longer term. And at the bottom, you can see you want to determine the patient's vein characteristics as well. Are they a little bit of a difficult stick? Do they have better veins? And of course, each patient and their condition is, unique to this. Central venous access devices. For a line to be considered central venous, the tip does need to lie in the central circulatory system. So usually we have our tip sitting in the SVC. Non-tunneled CVCs, these come in single, double, or triple lumen, and they're placed percutaneously. The important thing you want to remember about the lumen options is the greater the lumens, the greater the patients are at risk for infection and also developing DVTs. Typically, CVCs are inserted in the IJs, the subclavians, and the femoral. The femoral, I think, are usually used for emergency purposes or if access is unable to be obtained elsewhere. But typically, we stay away from the femoral if we can. Tunneled CVCs, these are surgically placed. They're tunneled under the skin, and basically, these lines contain a cuff. They're made of something called dacron, and basically the dacron is a fibrin and a collagen deposition which helps to stabilize the catheter underneath the skin. Not only does it do that, but it actually helps to decrease the risk of infection. And only specially trained and educated staff may use these. These lines are typically found on 2 colon and 2 DSU on patients that are heart failure that are going to be going home on inotropes. We have our metaports. These are surgically implanted underneath the skin. Same thing, the tip lies in the SVC. Because the port is not externally exposed, they're less at risk for infection. However, when accessing the ports, these are only done by specifically trained nurses. When accessing the ports, it does need to be done under aseptic technique. And metaports are typically used for chemotherapy, TPN, or if patients are requiring multiple blood products. Yes, be careful, distinguish from a pacemaker. One of the ways you could tell if a patient has a port and a pacemaker, you can just take a look at the chest x-ray. Usually the ports these days are power injectable. So if you take a look at the x-ray, you'll be able to see a CT on it. That means it's power injectable. And these ports can come in single or double like ports, reservoirs, I'm sorry. And so these ports have to be accessed with a special type of needle. They're non-coring needles. Again, you have to be trained to access 7 Monty, 8 Monty, and our team usually will access these ports. Moving on to PICs. PICs are placed above the antecubital area of the arm, usually into the basilic, brachial, or cephalic veins. Our team places PICs at the bedside. Sometimes patients do go down to IR for PIC placement. This is done under fluoroscopy there. The reason for that is because if we've tried them at the bedside, they're a very difficult stick. If we somehow can't get the guide wire to go or the catheter to pass through, we'll send them downstairs. Or if the patient is historically known for a difficult access, we'll send them down to IR as well. If they are at IR getting the PIC done, they can use it right away. They don't need a chest x-ray, but for bedside placement, we do need to confirm placement with a chest x-ray immediately after. We do use ultrasound to place the PICCs, and we use something called a Sherlock. It's a device that sits on your chest. This device helps us to guide the catheter down into the SVC, but we still need a follow-up chest X-ray to confirm. Yes, if the catheter tip is not in the SVC, the device can be used as a midline. However, if the patient's getting like chemotherapy or TPN, it cannot be. So it's really dependent on the treatment that the patient's getting. If the PICC ends up being a little too short, that happens sometimes, our team can change it over a guide wire to a longer PICC. HD catheters, so really only dialysis nurses or ICU nurses are able to access these catheters, and dialysis nurses are usually the ones that change the dressings every week or as needed. Central line catheter insertion. So informed consent must be obtained before the insertion. We use the same insertion note and the checklist. It's usually 2 people at the bedside. One is the performer, one is the observer. And this is a sterile procedure. So sterile gloves, gown, mask, and caps must be worn. And yes, again, the line needs to be confirmed with the chest X-ray immediately after placement. This is our system policy on central line maintenance. And of course, the one most important thing that you can do to help prevent infection is hand washing. Central line maintenance. So we use 2 different types of dressings here. We use the CHD dressings and we use the regular transparent dressings with the biopatch. It's really important that those clear windows sit directly above the insertion site. Needs to be firmly placed and adhere to the skin. And it's important that we could see that insertion site so that every shift our nurses can do proper assessments and look for signs of infection, purulent drainage, redness at the site, if the patient's complaining of pain, tenderness at the site. You know, there's so many things. Also, like kinks in the lines. You know, those are all things that we should be able to visualize during assessment, and it should be charted as well. Any central line port that's not hooked up to a continuous infusion should be flushed at least once a shift, and we recommend the push-pause technique. This is when you push 1 cc at a time. The reason for this is so that we can build up a little bit of like a turbulence in the catheter so that we don't have any of the fibrin adhering to the insides of the catheter. Central line dressing changes. Dressing changes should be done at least every 7 days, or again as needed if the dressing is bloody, if it's leaking, if it's coming off. Should be dated and labeled as well. And I think only demonstrated nurses, competency nurses, are able to change sterile dressings. A couple of complications. If we have any clotted CVCs, the provider should be notified immediately. They can sometimes give something called cath flow. If there's any punctures or leaks at the site, this is why it's so important to not use scissors when changing the dressings, because sometimes it's really easy to nick the catheter. If this happens, there's a chance that the line could be changed over a guide wire, but we try to prevent that. Discharge considerations. So patients can go home with D-access lines, they can go home with PICC lines, and it's important to just educate, and Metaports, of course, that are D-access, important to just educate them on care of the lines once they get home. But usually if they're going home, they already have home care set up. So that nurse usually comes in at least once a week and helps with the dressings and maintenance of the line. These are our different, I don't think you could see the top part, but these are different types of lines. This is great. I think there's handouts available in the back as well. As far as removing lines, providers can remove central lines and PICC lines, and nurses can remove mid lines at the bedside. Some common questions are who can remove central line, like I just said, providers can. Usually our team does not. Who can change the dressings? So usually just competency nurses and dialysis nurses can change the dressings. We change all of the PICC dressings and all of the power midline dressings in the hospitals. And we manage the Metaports except for 8 and 7 Monty. And a central line, how long can it stay in place? Well, we try to keep them for the shortest period of time that's required for treatment for the patients, because of course, the longer you keep central lines, the greater you are at risk for infection. I'm going to pass this over to Cameron.
Hello, my name is Cameron. I work in the MICU. I'm going to be talking a little bit about peripheral catheters and then also arrows. So for our peripheral catheters, this is one, unlike a central venous catheter that we spoke about, it is just starts and ends in an extremity. These cannot be placed when there's a do not use band. We all know those pink bands. And we must flush these every 12 hours, so at change of shift. And we do that with our sodium chloride syringe. So sometimes we may see patients with EJs. These aren't commonly placed. They're really emergency access that might be placed in the emergency room. So these EJs are considered peripherals. They must be placed and discontinued by a physician and PA or NP. And we try to do this as fast as possible. We try to get alternate access, either peripheral or central, as soon as possible, but definitely within 24 hours. The same goes with lower extremity foot IVs. So we try to change these ASAP, but if not within 24 hours, we really try to establish access elsewhere. If a patient has a foot IV, they must be on bed rest until that's discontinued. We really just try to avoid these because there's a higher risk for embolism and thrombophlebitis. And we're just going to assess this per protocol until it's taken out. This is an extended dwell catheter, so some of you might see these. We call them arrows, that's our carrier. So basically an extended dwell catheter is a peripheral IV. It's between 6 to 8 centimeters, and we put them in the lower or the upper arm. So someone who might need an arrow is someone who has difficult access. We need to do long-term IV therapy on them, and these extended dwell peripheral catheters are placed under the ultrasound, so they can kind of get those deeper veins that maybe we can't see or feel when we're putting in a regular peripheral. So these can last for 30 days. Our manufacturer that we carry here is 29 days, so just a little discrepancy, but generally for 30 days. And the only people who can place these are licensed healthcare providers who have a validated competency. So a midline, sometimes when you see an arrow on a patient, you might get confused. Is this a midline? Is this an arrow? The difference is that a midline is definitely longer. So while arrows are 6 to 8 centimeters, the midline is 7.5 to 20 centimeters, and is normally placed in the basilic vein, or the cephalic or the brachial. And the tip is positioned kind of by the axilla, but not quite at the shoulder. The same thing goes for midline catheters. Someone who might need a midline is someone who's difficult to get IV access on, or needs continuous therapy. So it doesn't enter the central venous circulation. It is considered a peripheral. So we have less risk for CLABSIs there. There's some contraindications for the midline catheters. So some medications and fluids that we cannot run through are high volume infusions, so high pressure boluses, high glucose concentration, so anything greater than 10%, or with a protein concentration of greater than 5%. continuous vesicant and chemotherapy infusions. So that would be like pressors. TPN cannot go through the midline, and also solutions with an osmolarity greater than 900 milliosmoles per liter. Then for contraindications of an actual use and putting in a midline would be conditions that impede venous return, anyone with prolonged bleeding time, it's pretty invasive, orthopedic or neurological conditions that affect the extremity, increase venous flow to the extremities, and then someone with an AV fistula or someone who we're preserving the arm for an AV fistula, we're not going to place the midline. This is a nice graphic. It kind of breaks down the difference between our regular peripheral IV, our arrow extended dwell, and then a midline. So we can see that the arrow is definitely right in between that midline and that peripheral at 6 to 8 centimeters. Similar to the midline, it can stay in for 30 days, whereas our peripherals have to get changed every 4 days. So certainly on someone with difficult access, this is nice to not have to change every 4 days. We cannot draw blood off of any of these catheters. So we can draw only at the time of insertion, but after that, it's considered a dirty line. In terms of who can insert these catheters, all of our RNs, we can insert the peripherals. MICU RNs with a demonstrated competency are able to place extended dwell peripherals, so we're able to place arrows. Hopefully that'll expand soon. Yay!
Is actually our first NICU nurse that is competent to do that.
Oh, congratulations! Yay! Yeah, so that'll be great once, a lot more people are competencied. And then for our midlines, it's our vascular access team or a provider. Anyone can remove any of these catheters. And then in terms of dressing changes, we can change our peripheral dressings. The vascular access team or any RN who can change a central line dressing is able to change the arrow dressing. And then the same goes for the midline. Patients can't be discharged home with arrows. They can be discharged home with midlines if it's deemed appropriate, but the arrows have to come out just like a regular peripheral. So some frequently asked questions: can vasopressors run through a peripheral IV? So vasopressors cannot run through a peripheral IV except for the MICU and the emergency room. Those are two areas where we will run vasopressors peripherally, but generally we're going to get central access. How often should PIVs be assessed and monitored? So you guys know you do this on your shift. So in critically ill patients, it's every 2 hours, and then all other patients are every 4 hours. Depending on what's running through it, sometimes it might be ordered more frequently. And does this mean I need to document my IV assessment every 2 to 4 hours? You should be doing your assessment every 2 to 4 hours, but you are able to document in the plan of care in a more descriptive way. So if you document at your shift assessment that you assessed it, then you could put in your plan of care that you did it every 2 to 4 hours. That's appropriate. Some intravenous therapy review. So all of our IV fluid bags should be labeled with date, time, initials, the patient's name. And then in terms of changing these bags, we're going to change it every 24 hours, or we're going to change it every 12 hours for lipid-based medications. With our IV tubing changes, that should also be labeled with date, time, initials. So you're going to change those IV tubings every 96 hours for continuous drips, every 24 hours if it's TPN or an intermittent therapy, and then every 12 hours again for lipid-based medications. If it's blood, we're going to change that with every unit. And then just another tidbit, TPN must be infused through a dedicated central line lumen. So once you use that lumen for TPN, you're not going to use it for anything else. The same with the lipid-based medications, you're going to try to get a dedicated lumen for that. And now I'm going to welcome up Amanda.
Right. Hello, everyone. My name is Amanda. I'm a nurse on 7 Monte. So far we've been talking about all different access that patients can have. So I'm going to be honing in on central lines, specifically talking about CLABSIs, our stats here in the hospital, and then our prevention strategies here. So first, just to quickly go over, everyone really knows what CLABSIs are, but our central line associated bloodstream infections. So these are infections that originate from our central lines. It's in a CVC when it's in place for 2 days or greater prior to that culture. And also it's in, well, like I said, in place day of or prior to that culture. And they also are exhibiting signs and symptoms of infection. So some complications can be due to prolonged hospital stay. CLABSIs can also increase the healthcare costs, morbidity and mortality, and the average cost of treatment to treat a CLABSI is around $48,000. And there are like 250,000 CLABSIs occurring annually in U.S. hospitals, 80,000 of which were in the ICUs. So before we go into really our statistics in our hospital here, I just want to talk about a term that is commonly used called SIR. So it's the standardized infection ratio. It's basically comparing the actual number of infections to our predicted number of infections. So when this SIR is 1, that means the number of infections is the same as the number that we predict. When it's less than 1, which is what we want, it's when the number of infections is less than what we predict. And when it's greater than 1, the number of infections we have is greater than what we predict. So like I said, we want it to be less than 1. However, the Center for Medicare and Medicaid have a lower threshold of 0.86. So we want it even lower than that to meet that threshold. Also, to just discuss quickly the mucosal barrier injuries. So those are bloodstream infections caused by oral or intestinal microbia in patients with immunocompromised conditions. Patients will have to meet certain criteria in order to qualify that they have an MBI. Those criteria, which we see a lot on 7 Monte, allogenic stem cell transplants within a year of receiving transplant. They would also have to have symptoms grade 3 or 4 GI graft-versus-host disease or greater than 1 liter diarrhea in a given 24-hour period. Also, they could be neutropenic within a 7-day period of that positive culture, and they have to be positive for those specific MBI organisms. So it's not all organisms, there's one specific for MBI. Here's just a quick chart to go over North Shore's CLABSIs. So just to look at the bottom to focus on between 2021 and 2022 with ICU and non-ICU CLABSIs. 2021, we had 22 total, and in 2022, it almost doubled to 39. Our 2022 SIR was 0.94, so it's great that it's under that 1. But again, for Center for Medicare and Medicaid, we want it under that 0.86, so just a goal for us in the new year. So there are 3 different routes of entry for bacteria for CLABSIs. The first is in the lumens where the medications are injected. We'll go into more of making sure that those lines are clean. The second is going to be when we're changing the dressings, making sure that our hands are clean, we're doing proper hand washing and having sterile gloves on. And the third would be the skin where that central line is placed, making sure it's clean during placement and then also cleaning with every week. So some of our prevention strategies, some of which occur in interventional radiology when the sites are being placed, or with the peripheral, the vascular access team, making sure there's aseptic technique and using the insertion checklist, having a sterile barrier, sterile field. The rest is going to be on the floor with the RNs, making sure there's proper hand hygiene, scrubbing the hub, making sure to clean our dressings and change the dressings once a week at least. Making sure when we do blood cultures, we're doing it properly to policy, and I'll go through that in a little bit. And then also surveillance, looking for any signs and symptoms of infection. So the first, of course, hand hygiene, we want to make sure that's top notch, whether it's with soap or an alcohol base like Purell. And then nail etiquette, making sure we have short nails, nothing like glued ornaments on our nails, that there's no chipping, that, if we're doing a dressing, nothing gets infected. So to increase our compliance, we have a good relationship with infection prevention. So we have these leapfrog monitors that you might have seen on some of your units. So these have cameras on either side that are placed in the hallways that are watching hand hygiene through both sides of the hallways. So here we just have our compliance from this past October and November. So we were at a little over 7,000 observations with our sites at 13%. But then we also had Hello 2s on direct observations that were good at 81 and 99% for November. So with scrubbing the hub, we just want to make sure 5 to 15 seconds of vigorous scrubbing with either your alcohol swabs or the CHG preps. Scrubbing the whole hub, disinfecting every time you introduce something new to the central line. And we don't want to reuse the pads multiple times. It's a one and done. We also are going to be changing that blue clave you see every 7 days with the dressing change at least. However, if it's damaged, leaking, there's something malfunctioning, we want to just replace it. So with IV tubing, here's just a couple images of some poor practice on the right-hand side. So the top one is going to be showing you just say, you're disconnecting something, you want to give a medication, you have to change something, you are just putting that line, just leaving it on, say, their bed sheet or the cloth or on the side. That line is now exposed and you would have to throw that out and get a new one. Another poor practice is going to be that photo below, where it's looping that line around into a dirty connection. That was another instance where you would be throwing everything away. On the left-hand side, we have our best practice, would be to use the white sterile caps that are stocked on the floors anytime you need to disconnect and then reconnect the same line. So for our central line dressings that are going to be at least once a week that we're changing, we want to make sure we're performing 30-second CHG scrubs in a back and forth motion, but then also allowing another 30 seconds for it to fully dry before applying a brand new dressing. For these dressings, like was said before in other presentations, we want to make sure everything's labeled with date, time, and initials. It should be changed every 7 days, if not sooner. Also, you want to make sure you're assessing for if the gauze, the dressing has any weeping, bleeding, anything that needs to be changed at that 24-hour mark or before that 7-week mark. So here's a good image from 3M. 3M also came to a bunch of floors that have central lines the most. I know they came to Seven Monte, where they demonstrated some signs when the central line looked good. We don't need to change the dressing unless we're at that 7-week mark. And on the right-hand side, if we're within that 7-day, we want to change it. So the top one is going to be showing how blood is spreading to outside of that CHG pad. So we want to change for that instance. Also right below, you'll see that the CHG pad is boggy, it's cloudy. That means that there was something leaking, so it got wet. We want to change that because we can't fully see the insertion site. Also right beneath that, we have that the dressing is pulling up a little bit. So in that case, we would also just change it before that 7-day mark. For when we're changing our dressings and we're going to be removing them, we want to use a low and slow technique. Starting from the outside and working our way inwards, you can use some alcohol pads to make it easier, less painful for the patient. But then also you can take a sterile flush and put a few drops on that CHG gel, and that can help remove it much easier. Also, anytime if a patient needs to take a shower, anything that we need to cover the dressing, we have our aqua shields on the floor to protect it better. For flushing and blood draws, like we said before, we want to use that push-pause technique, pushing 1 cc at a time, decreasing fibrin and platelets, and also decreases any bacteria. For blood draws through a central line, it does cause the risk of infection, so we want to do peripherally when we can, but we'll go into when you have to do in the order states to draw this centrally. So with assessing your central lines, you want to make sure you're assessing the patient and the insertion site for any signs and symptoms of infection, and then also assessing the access device and making sure everything is functioning properly. Every patient that has a central line should have an order for a daily CHG bath. This will be an order in the EMAR for either the CHG 4% liquid or the 2% cloths. For the 4% liquid, that is soap that should be directly applied to the patient with a washcloth. It shouldn't be placed into a basin, diluted with any water. It should be just as is. You'll be lathering from the extremity to the torso. And then also you're going to keep that on for about 2 minutes, then rinse with some clean water and pat dry. For the 2% wipes, you're going to be bathing the patient using all 6 wipes that come in each package. Each one, you'll use one part of the body and then throw away. So 1 wipe for both arms, 1 for the chest and abdomen, 1 for the groin, 1 for the right leg, 1 left leg, and 1 for the buttocks. You're just not going to use above the neck and internal genitalia. And this, you're not rinsing at all. A lot of patients will say sometimes they'll feel a little sticky, but that should go away in a little bit. And then also you can speak to your patients about what lotions they have. Some lotions that are coming from home aren't compatible with our CHG, so you want to discuss that with them, and they can always use the hospital lotion. When obtaining blood cultures, normally you're going to be getting 2 sets of blood cultures, except for the case if there's suspected bacterial endocarditis. That's when you're going to be getting 3 sets of blood cultures. So you want to make sure you're using clean gloves, washing your hands before each set of blood cultures. Always going to want to draw for the aerobic bottle first, then the anaerobic. And they should be drawn before any other specimen. If you have a CBC or CMP to draw, always do blood cultures first. On the blood culture bottles, you'll see there are 2 lines. You're going to initial, date, time, and document the site for each culture. You want to make sure you're filling it properly. About 8 to 10 mLs is best. And we're not supposed to be using any pediatric blood culture bottles. It should always be the adults. And volume of blood that we're drawing, we want to make sure 8 to 10. So at the bottom, we have a little chart of what North Shore's hospital-wide fill volume was. So in September, we were at 7.5, but getting better. October, November, we were above the 8 mark. So blood cultures should be obtained peripherally unless there's a specific order stating that they should be drawn from a central line. You want to utilize that blood culture collection kit because it contains the CHG in order to clean the skin. Also to keep in mind, if you're cleaning the skin, then you go to touch the vein again, make sure you're cleaning again. Also, the alcohol pad is in there to disinfect the top of the bottles. Once you take the tops off of each of the blood culture collection bottles, you want to make sure you're cleaning those as well. So part of the reason why we prefer that blood cultures are drawn peripherally is when they're drawn through central lines, it can be colonized and result in those false positives. So just to go over, again, more step by step for collecting those blood cultures, we want to make sure first that we're changing that blue clave every time you collect the blood culture so there's no false positive that's kind of living within that blue clave. When we're drawing from a triple lumen central line, we want to draw from the non-wire hub. So typically the wire hub is going to be the brown port, so either the white or the blue is your best bet to draw from. You're going to be first flushing with 5 to 10 mLs of normal saline and then discarding that amount that you're using and discarding that, you're not using that. If you have to draw 2 sets, both from the central line, you want to wait at least 5 to 15 minutes between each set and try to draw from different lumens then. So doing maybe one from the white and one from the blue. And then again, scrubbing the hub every time you're introducing something new with the CHG or alcohol prep. Here are our numbers from September to December for the hospital. So the national benchmark is 3%, and we've drastically improved that. From September, we are at 3.2, and last month we are at 1.8%. So hopefully keep in that direction. And then lastly, just to briefly talk about MRSA prevention, as that can drive up our CLABSI rates. Certain units have had different initiatives implemented by the Agency for Healthcare Research and Quality, 6 Tower, 4 Monty, 5 Monty, and CTU, where they're MRSA screening all of their new admissions, and those that are positive will receive nasal mupirocin and also doing those daily CHG baths.